questions you want to ask?
No, sir.
Okay.
So, my next topic, the next topic is 35-year-old third gravida developed severe hemorrhage after emergency LSCS. How to proceed? Mm. This is a case of third gravida developing severe hemorrhage. So I would suspect it is as a case of postpartum hemorrhage, probably due to uterine atony, as it is high parity, third gravida. First, I would recognize the early warning signs of major obstetric hemorrhage by non-invasive monitoring present. Uh, uh, I would maintain airway breathing and circulation, administer 100% oxygen by face mask, establish 2 large bore IV lines and a large central venous catheter if time permits. I would send the blood samples immediately for cross matching, 4 to 6 units of packed RBCs and 4 to 6 units of FFP, and simultaneously send for blood investigation for complete blood count, RFT and coagulation profile. If point of care is available, like TEG and ROTAM is available, I would send those samples. Meanwhile, I would start rapid infusion of warm saline and replace by RBCs as soon as possible. Initiate the massive transfusion protocol. I would also ask the lab and transport staff should be alerted for immediate issuance of the blood components. Crystalloids should be given at 1.5 to 2 liters, and colloids at 1 to 1.5 liters can be given until the blood is given. Not more than 2 liters is advised because of the risk of dilutional coagulopathy. Uh, I would also use blood warming or fluid warmers and also blankets to avoid hypothermia. Um, in case of also some uterine massage with bimanual compression and continued infusion of oxytocin. Coming to oxytocin infusion, 0.3 to 0.9 international units per minute IV infusion is given. Other drugs which can be given includes methyl ergometrin, 0.2 milligram IM. Carboprost 0.25 milligram IM can be given, and misoprostol 600 to 1000 mics per rectally or sublingual or buccal. If hemorrhage persists and atony persists, administration of multiple classes of uterotonics can be considered. Um, if surgical intervention and hemodynamic stability is compromised, I would go for general anesthesia. Rapid sequence induction is usually preferred, and usually induction with ketamine 1.5 milligram per kg IV is preferred. Invasive techniques include balloon tamponade, uterine compression sutures, embolization of artery supplying the uterus, surgical ligation of the artery, and the last resort of choice would be hysterectomy. Coming to the blood component therapy, O negative blood is given if there is any delay in the blood group specified, and the ratios of PRBC to FFP given is usually 1:1. In obstetric patient, always the fibrinogen level is maintained at a level of more than 2 grams per liter. We can also consider one dose of tranexamic acid 1 gram over 10 minutes slowly, and also a second dose can be given after half an hour. Maintenance of calcium chloride during hemorrhage is preferred. 10% of 10 ml of calcium chloride per 4 units of PRBC is given. And the last resort, if this is not possible, would be a cell salvage therapy if the mother is refusing blood transfusion. Our treatment goals would be uh, maintaining a hematocrit of more than 0.3, platelet of more than 1 lakh, fibrinogen of more than 2 gram per liter, ionized calcium of more than 1, and temperature of more than 36 degrees Celsius.
Very good. So this is the common thing that is given in every textbook and every article that you read on management of postpartum hemorrhage. What are the types of postpartum hemorrhage? You said the cause is uterine atony. I'm not asking the cause. There are 4 T's commonly prescribed as the causes of atony. I'm asking, can PPH be classified? What are the types?
Primary and secondary, sir. Primary, which occurs within
primary
24 hours.
that is not the term to be used for that. Primary is for spontaneous pneumothorax. Primary, secondary is there. For PPH, it is not called primary and secondary.
Which occurs within 24 hours and which occurs after 24 hours to
After 24 hours, okay. Any other classification? Like the airway?
Immediate and delayed, sir?
Immediate, and that's what she mentioned. Primary and secondary. Primary within 24 hours and secondary after 24 hours due to infection, retained products and all those things. Soundarya?
Sir, no idea, sir.
No idea. Vidya? I gave you a clue, like the airway, difficult airway classification.
Sir, you said 4 grades of hemorrhage based on the percentage of blood loss, 15%.
No. That is about the hemorrhage classification. Class 1, class 2, class 3. That is common for trauma as well as any hemorrhagic situation, whether it is due to PPH or massive major trauma or even surgical trauma, bleeding. Any hemorrhage you can classify into 4 grades.
Obstetric causes, maternal causes.
Obstetric causes and maternal, they're all etiologies. I'm asking about the types.
Reactionary hemorrhage.
Reactionary hemorrhage comes under secondary. How will you classify difficult airway?
Difficulty in Moscow.
Some cases, you know, it's going to be difficult, like a case of PM joint ankylosis or a case of CA oral cavity, a case of Peary-Robin syndrome. All these things, you know, you may have difficulty. What do you call that sort of difficulty?
Mild, moderate, severe.
Anticipated and unanticipated.
Difficulty airway. Very good. So like that, PPH also can be classified as anticipated PPH and unanticipated PPH. Okay. Which conditions produce anticipated PPH? In the antenatal period itself. You know,
placenta previa will be there.
placenta abnormalities of placental implantation, placenta previa, placenta accreta, placenta percreta. Okay, so all those things where you already know that the patient may have a postpartum hemorrhage, you can do preparations in that situation, because this is an article where I read about the updates in the management of PPH by Saudi Journal of Anesthesia, and I found some new interesting things, and maybe your examiners, if they have read that article, then they may ask you all these things. So I thought, instead of talking about the mundane, again, regular things which are all given in all the regular PPH management articles and textbooks, like what you said, how to arrest, mostly it is due to atony. And I thought I will add some more points to your knowledge so that you will be prepared to face such questions in the examination. Okay. So if it is an anticipated postpartum hemorrhage, then you can, what is the preparation you can do to avoid the PPH or patient suffering from that complications of PPH? Just logically think, the same treatment that you are now describing after the PPH has occurred, after an LSES, you can any of those treatments be done prior so that you can avoid the excessive bleeding before it happens? I'll give you a clue. It can be done by interventional radiology.
Uterine artery embolization.
You can keep an uterine artery embolization or balloon ready so that once the patient has delivered and you try to remove the placenta and there is a bleeding, you can reduce the blood flow to that area and try to prevent the occurrence of PPH. What is the risk of PPH? When you allow the patient to bleed, what are the things that can kill the mother? How will you classify the end stages of PPH, untreated PPH? What are the things which are going to lead to the maternal mortality, or what treatment can result in maternal mortality when you try to correct the PPH? Is my question understandable? You are able to understand my question? What will happen if you don't treat a mother with a PPH? For example, this complication occurs in a remote primary health center area, and mother starts bleeding after the LSC. Nowadays, you know, they want to do cesarean section in primary health centers also, and they do the LSCS, they deliver the baby. After that, mother starts bleeding because the uterus is not contracting, and they are living somewhere in a small primary health center area. She has to be transported to the nearest hospital, where you do not know whether they will have a proper blood bank and facilities for all the blood transfusion and blood products availability. So what will cause a maternal mortality in such situation when timely treatment is not available?
Hemorrhagic shock and
Mother will die
hypovolemic.
of grade 4 hemorrhage or class 4 hemorrhage. She will lose all the blood in the body and go to class 4 hemorrhage and die of that particular complication. Okay. But if she reaches the hospital and they start the treatment and you give the treatment, what is the complication of transfusion treatment that can kill
Dilutional
the
coagulopathy.
coagulopathy and hypothermia? Okay, these are the two complications which can result in the death of the mother. Okay, so we want to avoid all those things by adequately treating and preventing further bleeding. At the same time, restore the blood volume as much as possible. This is the basic concept of management of PPH. And if it is an anticipated problem, you can be prepared with adequate blood products. Plan the entire delivery itself in an institution where you have a well-equipped blood bank. You know what is the blood bank rounds that they talk about when you order for replacement of blood from the blood bank? Now they use a terminology called blood bank rounds. Have you heard of the term?
No, sir.
Not at all. Anybody else who have heard of that terminology? Where you say when you order for blood, you give a SOS call to the blood bank. There is a patient in the labor ward or in the maternity ward where she is bleeding. It's a case of PPH. We want we are starting blood transfusion. We want the supply. So that is called the rounds, where they are supposed to supply certain quantities of packed red blood cells, FFP, platelets, all these things. Okay. So until you say stop or deactivate, the modern blood banks are supposed to keep sending rounds after rounds of these particular loads of PRBC, FFP, and platelets. Okay. So that is the interest or the care that is being given to prevent maternal mortality in cases of PPH in the Western countries. Okay. Have you heard of non-pneumatic anti-shock garment?
Yes, sir.
Yes, sir.
What is that? What does it do? We have heard of pneumatic compression stockings and pneumatic compression devices during intraoperative period to prevent what complications? DVT. But here there is a garment called non-pneumatic anti-shock garment. What is it and how does it help in the treatment of postpartum hemorrhage?
Sir, it compresses the abdomen and the pelvis. decreases which increases the central blood supply and also increases the peripheral resistance.
So when should it be applied? How does it help? So to get also answers for all that, I have made a small OSCE-like preparation also with that. We'll just see that. I'll share the slides with you. Okay, so this is the picture that is it visible screen?
Yes, sir.
Yes, sir.
So anticipated PPH, where it can happen. The special antenatal preparation for abnormal placentation, or patient may have inherited coagulation disorders, or Jehovah's Witness patients. They're all patients who can have PPH, which can be anticipated. In those patients, we can do some preparations like surgical management of placenta accreta is done by scheduling delivery in an appropriate surgical facility with prophylactic embolization catheters in the uterine or internal iliac arteries and a rapid diagnosis of postpartum hemorrhage. And optimal anesthetic management is done by oxygen supply using warming devices, ensuring wide bore IV needles, access to adequate volume replacement, and blood product preparation. So this non-pneumatic anti-shock garment could be the first aid compression device. So whenever a patient, as I told you, has developed a PPH in a remote setting, until you transfer them to a tertiary institute with all the blood bank facilities, this non-pneumatic anti-shock garment is a very useful equipment which is now being advocated for applying to the mother and it has proved to be a very important step in the management of preventing mortality because of severe hemorrhage in the patients. So permissive, there is another terminology called permissive resuscitation, uterotonic administration, tranexamic acid, recombinant active factor 7A, and lyophilus fibrinogen concentrate are also beneficial for the treatment of the mother. What is this permissive resuscitation? Any idea about this terminology? Sanjita?
Sir, no idea.
No idea.
Up
Okay,
to
we
2
will see that
liters
also.
of fluids can be given.
Pardon?
Up to 2 liters, 1.5 to 2 liters of fluids can be given.
It is not about the fluid administration. Just like your permissive hypercapnia, you are used to the term, isn't it? Where do you use the term permissive hypercapnia?
Laparoscopy and COPD patients.
COPD, ARDS management,
Protective
in all those things we say permissive hypercapnia up to a particular limit, say even up to 60 millimeters of CO2, we say it is permissive hypercapnia as long as the oxygenation is okay, isn't it? Similarly, this permissive resuscitation is a term which has been used with an additional wording in between. Can you guess or make a logical guess of that wording in between this permissive and resuscitation? It is actually a 3-letter word. I have given only 2 letters, permissive and resuscitation. In between, there is another word with regard to the hemodynamic parameter.
Mean arterial pressure.
Permissive hypotensive resuscitation. Okay. So with a mean arterial pressure of 50 to 60, if you are able to maintain, you need not worry about the systolic and the diastolic. Okay. That is called permissive hypotensive resuscitation, where you don't rush too much of fluids and exaggerate the volume in the circulatory compartment, which will aggravate not only bleeding more, but also cause tissue edema and cause more problem. So just like the trauma management, they have borrowed this terminology, which is called permissive hypotensive resuscitation, where if you can monitor the mean arterial pressure and maintain it between 50 and 60 millimeters of mercury, the outcome is better in such patients rather than trying to achieve a blood pressure of 110/80 and try to get a mean arterial pressure of 90 or 100. Okay. Similarly, the hemostatic reanimation. This is another terminology which is given in the updated version of PPH management, which is mainly to correct the coagulopathy complication of that. And cell saver for auto transfusions are applied in the management. For unanticipated PPH, guidelines and regular pre-training reduce the incidence of severe postpartum hemorrhage is also another improvement in the management. Now, primary PPH occurs within 24 hours and it is due to 5 T's. Normally, all the books and articles give only 4 T's. That is tone, tissue, trauma, thrombin. Okay. What is the 5th T here?
Transfer the patient.
This is the cause of PPH, not the transfer. Transfer is a treatment, modality of treatment. Normally, all the books give only 4 T's. Tone, which is the atony, trauma, which is the damage or injury to the birth canal, tissue, which is retained products of placenta, and thrombin, failure of coagulation. And the 5th one that is given here is the uterine inversion. Sometimes, the whole uterus becomes inverted and comes out. That is the turning out of uterus. That is also included in this article, and that they give it as a 5th T. Uterine inversion or turning out of the uterus. And one of the drugs which has been implicated for the cause of PPH nowadays is the patients who are taking serotonin norepinephrine reuptake inhibitors. If they come for delivery due to some psychiatric problem, if they have been taking these medicines in the antenatal period, then there is an increased risk of PPH. Are you all aware of this point? Have you heard of this particular drug complication as one of the causes of increased risk of PPH? I came to know only after reading this article. The secondary PPH develops after 24 hours of delivery due to severe infection leading to uterine atony, retained products of conception, subinvolution of the placental site, and inherited coagulation defects. Now, the maternal early warning systems suggest close monitoring, and if the heart rate is more than 120 beats per minute, that is the earliest indication of the patient likely to go for PPH. So, a postpartum woman after delivery, if her heart rate is more than 120, that is the earliest warning sign. What is obstetric shock index? When you talk about this early warning sign of tachycardia in the postpartum mother, there is another index called obstetric shock index. Have you heard of that?
Sir, systolic BP by heart rate.
Heart rate by systolic BP, ratio between the heart rate and systolic BP. Normally, heart rate is 75 to 80. Systolic BP is 120. Okay. So when the normal value should be 0.7 to 0.9. Okay? So the only 70 to 90% of the systolic BP should be the heart rate. Heart rate should always be lesser than the systolic blood pressure. But in hypotension, what will happen? Heart rate will go up, systolic BP will come down. So the value may go beyond 1, 1.2, 1.3 like that. In that case, that means mother is losing a lot of blood and not able to maintain the systolic BP, tachycardia is occurring. So that also is considered as a very simple clinical method of assessing early warning sign of impending hemorrhage, which is called obstetric shock index. Okay. Heart rate in relation to systolic blood pressure more than 0 point is highly specific for PPH. So these two are considered as the most important reasons for the or the early warning signs for PPH, associated with an increased risk of blood transfusion and a reliable indicator of adverse maternal outcomes. Now, the laboratory investigations, not only the hemoglobin hematocrit, you must do serial hematocrit in these patients so that you can find out whether you are maintaining adequate RBC and hemoglobin, and serum ionized calcium, potassium, creatinine, and arterial blood gas are also indicated, and serious coagulation test to assess the development of coagulopathy. And the optimal approach to PPH are oxygen supplied by face mask, 10 to 15 liters per minute, wide bore IV access and warming devices to ensure normothermia, and use of non-pneumatic anti-shock garment. This has been a very important primary or early treatment before you transport the patient from a peripheral hospital to a tertiary center. This garment is supposed to save the life of the mother. And permissive resuscitation is a mean arterial blood pressure. So you always remember this: permissive hypotensive resuscitation with a mean arterial pressure of 50 to 60 millimeters of mercury. IV volume replacement initially with crystalloids, as we told. And hemostatic reanimation is early and aggressive blood product replacement. This is what is called the hemostatic reanimation. That is, you get back the normal hemostatic parameters. And that is being described as this terminology called hemostatic reanimation. And ensure sufficient blood product supply. And the lyophilized fibrinogen concentration, 2 to 4 grams, maintain the fibrinogen level of more than 2 grams. This is the normal level that we are supposed to achieve. Blood serum fibrinogen level of 2 grams per liter. And that will be done if you give the lyophilized fibrinogen concentrate. It is now available as a part of the blood product. It is 2 to 4 grams. If you administer IV, that will maintain the fibrinogen to more than 2 grams. And this will help in coagulation and prevent further bleeding. And if any intervention is needed, surgical intervention is needed, as you said about the B-line suture or the ligation of internal iliac artery or ultimately hysterectomy, they have advocated that combined spinal epidural or pure epidural anesthesia allows the mother to be awake and may be extended for prolonged surgery. So this is the technique of choice. Earlier, we were thinking that because the patient is hemodynamically unstable, central neuraxial blockade is not indicated. But if the coagulopathy has not set in and patient is in permissive hypotensive resuscitation, you can still go for a combined spinal epidural where you will be using only a very small volume in the subarachnoid space, and you can maintain the level required by additional epidural, or you can go for regular epidural and try to titrate your dosage to achieve the desired level of block. And general anesthesia will be preferred in cases with massive transfusion in the event of already some airway edema, fluid overload, or pulmonary edema has happened, or there is a transfusion associated lung injury. In such cases, it is better to go for GA and not to this regional technique. So what is permissive hypotensive resuscitation? What are the advantages of that? So permissive hypertension resuscitation aims to maintain a mean arterial blood pressure of 50 to 60 millimeters of mercury. It helps to limit blood loss following delivery. And it decreases multiple organ dysfunction syndrome, that is MODS, and also ARDS. Increased IV fluids leads to decreased concentration of fibrinogen, hemoglobin, and platelets. That is, causes dilutional decrease in the coagulation factors, and This PT and PTTP may lead to coagulation defects. So this is prevented by what is called the permissive hypotension resuscitation. And what is hemostatic animation? That how does it help? That is another terminology. It is the early and aggressive blood product replacement. That is what is called the hemostatic reanimation. Get back all the packed red blood cells, fresh frozen plasma, and platelets to correct the coagulopathy are given. Hemoglobin transfusion trigger is 7 grams per deciliter. So when the hemoglobin drops to 7 grams, you have to start giving mainly packed red blood cells. However, the transfusion should proceed without waiting for the laboratory results, depending upon the clinical hemorrhage that you can watch. And transfusion ratio is what is the, you give FFP to PRBC and platelet to PRBC in ratios of 1:1. So for every PRBC you give, you have to give 1 FFP. Similarly, for every PRBC you give, you have to give 2 platelets depending upon the amount of PRBC given. This increases the survival in massively transfused patients by the beneficial effect of plasma in the first 2 hours of resuscitation. So during the early resuscitation, this is the ratio at which we should give the transfusion. And platelet transfusion to be done with transfusion of 8 units of PRBC once initially if you have restored the hemoglobin more than 7 grams. And the rotum indicator, that is the parameter that is observed in the rotum, which is called fibrinogen temp A5 early PPH, is an indicator of platelet consumption. So that will, if you do the rotum, as you rightly said, the point of care testing, we have thromboelastography and rotum. What is the difference between TEG and rotum, Sanjita? The measurement of this coagulation.
Sir, in TEG the pin rotates and rotum the cup rotates.
Rotum, the cup rotates, correct. Okay, right. So that is the difference. And so the graph that you get will be more or less similar, but in the rotum you get the advantage of this particular terminology, which is called the clot formation at 5th minute, which is the fibrinogen template. And as you all know, initially it is the platelet which is important for the onset of coagulation. Later on, only the conversion of fibrinogen to fibrin happens. And if this value is low in the rotum graph, then it indicates platelet consumption, and you have to mainly give platelets at that level and not fibrinogen. And what is turnaround time by blood bank to manage BPH? How much is supplied at item? This is what I told you about. In the Western world, all the blood banks have been instructed that if they receive a call from the maternity side about a patient with BPH requiring blood transfusion on a massive scale, then the blood bank delivers blood products in rounds to the operating theatre when they receive the request. And rounds commonly consist of 6 units of PRPC, 6 units of FFP, and 6 units of platelets, or 1 unit of platelet apheresis and 10 units of cryoprecipitate. So these are all the package that will come, and that will help in, without waiting for further request, this will be kept on sending till you deactivate that or say stop, we don't want anything. Now, I don't know how many of you have seen what is shown here.
Non-pneumatic compression.
This is the non-pneumatic anti-shock garment. Okay, what is it used for?
Postpartum hemorrhage.
It reduces blood flow to the uterus and treats hypovolemia in a mother who has started bleeding. Before you transport, you can apply them. How does it work? It works by pressure applied to the by the NASG, serves to increase the resistive index in the internal iliac artery. it supplies the majority of blood flow to the uterus via the uterine arteries. So it increases the resistance in the internal iliac arteries, reducing the uterus blood flow. Something similar to blocking by embolization or ligation. This helps to reduce the internal iliac artery blood flow. And it also decreases the blood flow in the distal aorta. Okay? The advantages of NSAID are it is light, flexible, and comfortable to wear. It is designed to allow perineal access so that the examination and vaginal procedures can be performed without removing it. So this is how the thing is applied. You can see the number 1 goes to at the ankle level, number 2 at the upper calf and the knee level, 3 at the thigh level, and there is a pelvic and an abdominal binder. And you can see the perineal area is free, so patient can be examined also. So once this is applied like this, it should be transported with the application until resuscitative measures of transfusion and other things are started. This should be in place. They have found that removing this prematurely before starting the resuscitation has led to serious complication of maternal death. But when this has been applied and patients were transported, this has saved a lot of life. Okay. So after simple training, anyone can put the garment on a bleeding woman. And what is the pressure applied by this non-pneumatic anti-shock garment is, the pressure applied is 20 to 40 millimeters at all these compressions. So that is how the whole thing works. And that is the additional points I thought I will share with you.